Professor Vaiude is a plastic and reconstructive surgeon, surgical trainer and educational innovator. Partha completed his specialist training in Merseyside, where he gained a craniofacial fellowship at Alder Children's Hospital. It is here that he is also the lead surgeon for a unique hair reconstruction service that is being pioneered to offer reconstructive hair transplant surgery for children with hair loss from burns, injuries or surgery. He is the Managing Director and Faculty Lead for Surgical Art UK, where he spends much of his time teaching surgical skills and artistic perspectives for surgery. His goal is to advance surgical training methods and to bring to the forefront of training education lesser taught components such as ethical practice and an understanding of the art in plastic surgery. Surgical art aspires to provide the highest level of quality through innovation or collaboration in every course. And Partha has a number of innovations to his credit, including the face reconstruction mask, which is nationally recognised. Partha will speak about the Surgical Art UK journey and broadly about the challenges faced by plastic surgeons in regards to aesthetics and identity. I want to hand over to Partha.
Caroline, thank you for the invitation. Mark, thank you. Also, thanks to LASER for letting me introduce some of my ideas. My name is Partha Vaiude. I'm a plastic surgeon, reconstructive aesthetic surgeon, Managing Director, Surgical Art. Surgical Art is a training organization starting with courses, but we do a variety of other things, and I'll come to that in a minute. Okay. Artistic perspectives of the topography of the face. I mean, it's a bit wordy. Now, what does it really mean? I think it's easier for me to start with my own story. That's not me. That's actually my mother. My grandfather was one of the greatest artists India has seen, Rabindranath Dutt. He was a contemporary of Tagore, and they worked together. And these are some of his works. India was at a time when the Neo-Bengal school of art was developing, and there was a huge influence of Eastern, Japanese, Chinese art. You can see some of the logos, you can see the stylizing. And I grew up with all this art around me. My father was heavily influenced by Western art. And you can see the stylizing of posture and anatomical features. My father, who is a professor of art, also developed a simplistic narrative of folk art from India, and he and my mother produced some interesting work in different media. So I was quite lucky. I'm one of the few plastic surgeons who was sort of fourth generation artist. And so I took it for granted that every plastic surgeon has an artistic bend. Da Vinci was my hero, still is. The Vitruvian Man that is in Venice, the Academia, is an homage to Vitruvius. Most of you will know that Vitruvius was an architect who used the proportions of the body. He felt the body had the perfect proportions, and he used those proportions to design his buildings. And so Michelangelo designed the Vitruvian Man to pay homage to him. But some of his works on the skull and the face are historic and little known. The proportions and details that he was able to extract from his dissections seem to marry the world of surgery and art more than any other has done so far. Interestingly, a contemporary of his, Vesalius, was another enigma. He produced a series of books, and for the first time after Galen was able to bring to the fore an understanding of the body. But my heroes changed. Gillies, who is a pioneer of facial reconstruction, was the first man to bring facial reconstruction back since the time of Sushruta, who in 600 BC, an Indian scholar and surgeon, was able to design reconstructions, a forehead flap to design the nose or reconstruct the nose. Gillies was able to refine that and produce a fantastic result. So, borrow from one area and feed another and retain a fantastic result without leaving a deformity. But more than Gillies, this man is more important to this talk. Tonks was a surgeon, a general surgeon, who decided to leave his scalpel and take up the brush. He was a Slade professor of art, and he was sent out on the battlefield to paint war wounds and different scenes. But when he was back, he spent a lot of time with Gillies and painted patients before and after surgery. He was able to reach out and touch their lives and speak their stories more than anybody else has been able to. His works were kept hidden from public view until more recently. So why do we think of the topography of the face? Certainly from an artistic perspective. Well, the art starts in utero. These are images of a human, a normal human fetus. This is Gray's Anatomy. He has beautifully defined the facial subunits. The forehead blending into the nose, the maxillary processes coming together to form the cheeks and the upper lips, the mandibular. And this dance of different planes on the face go on to produce a fantastic pattern, which, if goes wrong, produce different forms of clefting. Clefts of the lip and palate as we know them. This is an image painted by someone in the crowd here. Thank you, Jessica. An MA student with John Moores and Caroline and Mark. She has hybridized an image, but so beautifully represents the scars, the pathology and the scars from the pre- and post-operative imaging of a cleft lip. Tessier defined facial clefting. He looked at bony clefting and skin clefting. And you can see that when things go wrong, they go against the natural lines of the face. These are Moyer imaging, looking at the harmony of the face, and they really help to define asymmetry. So it's used in facial palsy. And these images give us an insight into what a plastic surgeon or an artist looks at in a face. Are we looking for that perfect golden ratio? Are we looking for symmetry? Are we looking for shade and light? How does the face look in different perspectives? These are the questions that most plastic surgeons have tried to answer. But I don't think that anyone has really touched that union of science and art enough. And then my story progresses on from plastic surgery residency to a craniofacial fellowship when I was faced with these skulls. Each of these skulls represent a pathology of fusion of the skulls, of the sutures of the skulls. So in a baby, in utero and after birth, the plates of the skull are meant to stay apart. If they fuse too early, they force the skull to expand in an abnormal way, either too long and thin, too flat and tall, a bit skewed, with large openings, maybe even a bit pointed in the front, like a keel of a ship. And as a plastic surgeon, we have to touch and look at a thing in a three-dimensional sense. So to reach the skull, once we peel back the scalp forward and backward, we are faced with a skull that looks like this, and we have to redesign it by taking apart most of the skull, obviously leaving the brain behind, and the neurosurgeons look after that, to produce a skull that looks a lot more like this. And you'll say, that looks boxy and artificial. But actually, this is reality. We are dealing with a moving sculpture. We're dealing with a living sculpture, a bit like you. But a sculpture that evolves with time, and the body is trying to revert back to what it was doing before. And we are trying to push it in the other direction. So we overcorrect it, and then it returns to a relative normal shape, somewhere in between. And so this search for what is a normal shape led me to think about, what kind of surgeon am I? Am I a surgeon that measures many times before I cut, or am I a surgeon that follows lines and thinks artistically? And we all sit somewhere on that spectrum. I know where I do. But it also got me to think that working with different specialties within medicine gave me such a boost of understanding of the pathology of what I was dealing with. If I worked with other specialties outside that of medicine, the marriage of art and science. This is an experiment using fairly basic products, orange in a bottles really, balloons, to create a microsurgical flow system to practice microsurgery. And this is an isotropic fabric, a fabric that moves more in one direction than the other, to simulate a scar within a embroidery ring really. And you can see a scar which is released by a surgical technique called Z-plasty. But what do we do in plastic surgery? Yes, we do cosmetic surgery. But what a lot of people don't know is we do some interesting work in cancer surgery. So we take out tumors, small and big, and reconstruct them in different parts of the body, particularly the face. You've seen we do work on craniofacial defects. We reconstruct the skull, the skin, We even do surgery on the hands, burns. We reconstruct breasts, we reconstruct the scalp, lower limb. We take large chunks of the body from one part of the body to another to reconstruct it. And the same body or from another body. And this need for multiple skills delivered in an artistic way, with an artistic sense, led me to develop surgical art. Surgical art is just down the road on Hope Street. And what we do is innovate. So, Microsurgical Lab, using the highest technologies and interesting flow systems. We use communication specialists and actors to understand how to communicate and more ethically speak to patients. We use chicken bones to simulate the bones of a hand. You wouldn't believe it, but these are pig's tails to simulate fingers and reconstruct the soft tissue of a finger. We use carcasses of pigs to move tissue from one part of a body to another. But this is dear to me, the surgical art face. And I'll come to that in a second. When we move tissue, yes, this isn't a face, this is the chicken's bottom. But this is a good representation of how to move tissue from one part of a body into its adjoining space. And I think this is one of the most artistic and more challenging operations, because you're borrowing from Peter to pay Paul, and Peter is not always willing to give Paul. But when we create a defect, maybe for a skin tumor or a trauma-related defect, we have to release skin in a very artistic fashion, following the lines of the body to slide it from one part into another so that we can close a defect. We test the capacity of the body to close itself in one direction more than the other, and therefore raise flaps that follow the lines of the body, follow the topography of the body. We're also into horror films. This was not a popular model, as you can figure. Yes, the chicken model, we took it really to its extreme, and we try to create a face out of it. It actually works very well, but our delegates refuse to use it after a couple of goes. And you can see why. And so we started developing models that simulate the face. Now the face is not just a homogeneous structure. The face has multiple layers, and they work in a different fashion. The skin does its own thing. It works perpendicular to the muscles that are underneath, and the muscles are attached to each other by a layer called the SMAS, which is fascia and fiber interwoven with muscle, and that's tethered down to bone, surrounded by some fat. And so every part of the face, when pinched and moved, does its own thing. And that needed to be simulated in an artificial setting to be able to reconstruct, fill a hole by moving skin from one part to the other. So these were early prototypes, as you can see. And then with more and more experimenting, we came to design a more refined product that looked and behaved the way it should in surgery, or as close to it. And so we needed to make more. because there were lots of plastic surgeons that wanted to learn to do it, to do these operations. We took inspiration from Venetians. Venetian masks are fantastic. They have been designed around the subunits of the face. Angela is one of the last few true Venetian mask makers who works with her father, Victor, and they produced these masks. And we've been studying them, and the results are not yet out, but every one of these masks actually has an anatomical basis. We spent some time, and I actually designed some masks for Angela and Victor, and we're working on an experiment which marries Venetian art with modern surgical technique. Watch that space. What we do at Surgical Art is inspiring not just to the surgeons but to the artists who come to us. And Jessica Irwin, who you've seen her art before in the presentation, produced some of these images, which are fantastic representations of true surgery. It's amazing how we don't actually have good imaging even in atlases. But this is a perfect example of how tissue can be moved from an adjoining structure around the commissure or the corner of the mouth, the upper lip being used to reconstruct the lower lip. And this marriage of surgery and art led us to collaborate with Caroline, Mark, and Face Lab. And we developed this course called Artistic Perspectives for a Clinical Practice, where we used multimodal technologies and collaborative practices, where you can see here we're doing the more traditional tactile, haptic, sculptural technique using soft wax, moldable wax, which surgeons can feel, move, change. They worked from the skull, built muscle, and surfaced it with skin. You'll be surprised how many of these surgeons, some of them quite senior, really struggled with this exercise. Surgeons are not taught art. They're not taught, plastic surgeons, weirdly, are not taught sculpture or art. We're taught to perform safe surgery, not artistic surgery. So this was the first time a lot of them actually felt contour. We used digital technologies to, thanks to Mark, to manipulate the face. We used historic references to appreciate the way the concepts of beauty have changed with time. We then reverted back to the face, and we allowed the candidates, the delegates, to represent their own understanding of what can be done with face reconstruction and their understanding of the anatomical subunits. But actually the most interesting bit was this one. I don't know how many of you are aware of contouring. I had no idea. Makeup contouring. That was quite revealing for me. I think Mark as well. So we had a specialist who came and actually taught us how to contour a female face, a male face, how to exaggerate certain elements of the face, how to hide certain elements of the face. And this has a great impact on ethical practice. And you mentioned, Botox and fillers at a very young age and cosmetic surgery. Yes, there's a lot to be said about non-surgical interventions. And the question really is, in this day of changing identity, where media, peer pressure, there is a greater perceived need to change one's image, one's face, one's body. And as a plastic surgeon, I feel the responsibility is on me as a gatekeeper for this change. And the more I understand the body, the shape, the topography of the face and the body better, the more I'm able to ethically guide my patient. This is what surgical art is about. I'd like to thank my parents who have always inspired me with their art. The surgical art team, Amy, thank you for being my right-hand man, woman. Caroline and Mark, Jessica for your amazing artwork and inspiration. This week we have lost two greats, one in the world of science and one in art. I pay homage to them. Thank you.